end range refers to that final bit of motion in a joint's mobility. So for shoulder flexion, for example, going up here is not quite end range, but pushing it a little bit more is. We always need some form of external pressure to get a joint all the way to its end range, even if it looks like it's going as far as it can go without that pressure. That pressure can be the person's own hand, a table, the floor, the ceiling, whatever it needs to be. A clinician obviously can provide that overpressure as well to get the joint all the way to end range. End range is important. We need to understand behavior of joint mobility at end range. When I'm doing the physical exam, I will, in many cases, or most cases, especially in the extremity joints, apply overpressure to get to end range to understand how it behaves, how the joint moves during the motion and what it feels like, and then how it feels and moves at end range are both really important parts of the physical exam that help me to get to a diagnosis, because different pathologies will behave differently during active and passive range of motion and at that passive end range motion. But end range is also really important therapeutically when we are addressing mechanical joint disorders. A mechanical joint derangement, as put forward by McKenzie, is a mechanical problem in a joint that presents with local and or referred symptoms, limited and or painful motion in one or more planes of the affected joint. It possibly is accompanied by weakness, so to speak, nerve tension, and a few other different signs and symptoms. But it is 70 to 80% of what I find orthopedic disorders are when I apply repeated movement testing, which was created by McKenzie. When I add repeated movement testing to a patient's exam in part 3, I find in the majority of cases, when we take a joint to end range repeatedly, we can fix the patient's disorder. And that's the beauty of a mechanical joint derangement. If it fits those criteria and it responds repeatedly to a movement in a specific direction or two, then we call it a mechanical joint derangement. And we call the movement that fixes it the joint's directional preference. But end range here is important because getting the joint to end range is what we like to say where the magic happens. Moving a joint 80, 90, or 95% of its way, for example, into shoulder flexion or lumbar extension or knee extension, whatever it may be in the spine or the extremities, is usually not going to produce the best results. We want to take a joint to its end range. That does not always mean that on day one, I feel that it's safe and that the patient will tolerate a lot of end range movement. So taking lumbar extension as an example, lying prone just on the table is going to be neutral to mild extension of the low back, nowhere near end range extension of the lumbar spine, but maybe that's all the joints can take, or that's all I want to push. Going prone up on elbows is a bit more extension. Pressing up is a bit more extension. Adding overpressure with a belt or with a sag of the hips, which is generated by the patient, or maybe with my hands, then we are ensuring we're getting all the way to end range. For most patients, nearly all, we have to get to that full end range with some overpressure, like I said, to fully resolve the joint derangement. And I think many patients or clinicians who utilize repeated movement testing sometimes miss this aspect. And I make that point to patients. I'm saying, look, we're doing it this way because I don't think your joints can tolerate going all the way into full extension of the spine, but we need to get there. We're just going to go there cautiously so we can assess what happens and make sure we don't exacerbate the problem. In the extremity joints, however, I'm very often going to end range with overpressure on day one. For most people, it tends to be more tolerable in the extremities, whereas lumbar problems, neck problems, especially those that are radicular in nature, where they're hitting the nerve root and causing extremity symptoms that are true radiculopathies, we need to be a bit more cautious. For example, with neck retraction, I might not apply overpressure on day one. With retraction extension, I might not apply overpressure on day one either. But eventually the goal is to apply that overpressure and get to end range. Now that doesn't mean you won't see gains with movement to the patient's end range without overpressure to get to the full maximal end range. You will usually see gains or progress if it's the right motion, but it will often plateau if you're not getting to full end range to fully resolve the problem. In the extremity, it's a little unclear why getting to end range is really having an effect on a mechanical problem. The kind of pathoanatomy of what's happening in an extremity joint derangement is unclear and debatable and an interesting topic of conversation for me. But in the spine, I like to point out with patients that I do subscribe to the dynamic disc model. I think that's the model of best fit for what we're actually doing at an anatomical level when we have patients move the spine to end range positions, whether it be flexion, extension, side glide, right rotation, etc. And so for them, I kind of explain it like we just need to get to end range because we need to get all the way into that position to push things away from that force. So it's kind of like this. We're not going to get too much progress here, but then if we start to get to end range, we get all the way here, we can apply that sufficient pressure to make the changes that we need in the disc, if we use that as a disc model, or in whatever structure we're kind of attacking. But for me, explaining it like that helps people understand that we're not going to get the results we want just messing around with a little bit. In order to push structures to achieve lasting change, we need to get that joint all the way into the end range of the direction that we're attacking. Again, we're thinking it's often extension, but it's not always extension. Sometimes it's a lateral movement, sometimes it's flexion, and the load is distinct, whether it's standing or lying, etc. And of course, we're talking about force to get it to end range, but how we implement that force over time is, part of the clinical picture we have to decide for the individual patient. We don't want to do too much force too soon to make things worse. We obviously don't want to postpone the necessary force and not see results. That is kind of the dance we play with physical modalities. It's hard to understand how much force is appropriate, but getting to end range is what I want to point out today. We need to get there. When we get there is different based on the patient in front of you. We're typically getting to end range overpressure in the extremities more quickly because they're less fragile, but in the spine, it may take a little bit of time. But if you don't get to end range and you just leave a direction, right? Say you're doing retraction, it's not producing changes, the patient has no change, and you leave retraction and look to left side bend, for example, of the neck without applying some overpressure either on the patient's part or the clinician's part, you're probably leaving sometimes that retraction on the table when it was actually fruitful. You just weren't getting to end range. And I know it's not necessarily a huge difference visibly how much retraction one's getting with or without hand overpressure to get to end range, but we find that small amount of motion that's increased, getting to full end range versus 90% does make a difference.